fat grafting is an important adjunct of treating a person that perceives themselves to be aging, and we use 1 cc syringes from fat that's been settled from harvesting in abdomen or flanks of a female patient. A small incision is made via a 14 gauge venflon into whichever web space seems the most appropriate. The dorsal veins are separated and put under a degree of traction to avoid inadvertent cannulation. The blunt cannula passes easily into the subcutis. There's a lovely loose plane here. The veins flip around the blunt-ended cannula, and the fat is injected in a fan shape in and around these veins, and the idea is to create a degree of swelling which fills in the stigmata of the aging hand. So not only does skin improve by the degree of tension that's been put on it, but the guttering is filled in by the fat, the veins collapse because of the adjacent pressure, and the quality of the tissue significantly improve. So through this one little web space stab, fat can be fanned out all over the dorsum of the hand. But as you can see, that the most treatment is going on at the apex of the triangle that's been created. It is important that you continue with the fat grafting all the way to the ulnar border of the hand in this case, and onto the dorsum of the wrist to avoid a shelf type deformity. The fat is layered in, and although there aren't that many layers of fat into which to inject, it can easily be massaged into different positions. So it is important that when you're inserting this fat, you get to the periphery of where you objectively trying to put the fat itself. It is important that you go slowly. It is important you aspirate, and you are 100% sure that you're not injecting into any large vein. With regards selecting the donor site, I think fat for this type of purpose has a good chance of surviving over the long term, and therefore it's probably better to take from fat which is unlikely to change by weight gain or weight loss in that particular individual patient. So as I said, I tend to sort of choose the abdomen or the flanks, the posterior arms or the inner knees, and the most fat that I would inject would be up to about 15 mils, but usually it's around about some 5 or 7 mils of fat. And it's done very quickly. It doesn't take long to do. The tissues are just evened out, a little bit of massage that goes on, and quite clearly you can see the veins have almost like disappeared in appearance. The guttering has been completely filled. But just to be sure, I tend to make further incisions in other web spaces, avoiding the vein that goes on between the metacarpal spaces. Little bit of pressure prevents any undue swelling at that particular moment in time. The blunt cannula is inserted just underneath the dermis, and there it goes smoothly into position, and injecting 1 ml at a time into areas in fan shape, which then become homogeneous with the fat that was injected through the other incisions. Now the skin itself is quite elastic in this particular case. In others it'll be wafer thin, and in those patients it is important post-operatively to keep the dorsum of the hand cool to avoid swelling. If the hand swells inadvertently, it will take ages to settle down, and it is very, very important that there are no colour and long-term changes that go on.